That's
Oh, it
the
doesn't. Oh,
no, that's why I've got my camera over here and we are now live on everywhere. So hello, gorgeous one, Dr. Aziza Sesay.
hello.
Welcome. We are talking about all sorts of things that to do with unexplained and unexpected bleeding from the outside to the inside. That's the
Yep, yep.
coming plan. Okay, shall we start from the vulva and work in everybody's favourite spot? Because that is an itchy, burny, not very happy place for very, very many of us. And I think the quote of the day that I saw the other day was the secret to looking younger was having a happy vulva, because this woman was saying when it wasn't happy, she spent the entire time frowning and in pain. So, yes, unhappy vulvas and vulvas that bleed. Why do they do that?
Yes, yes. Thank you so much for having me. And I think this is really an important topic. Like, obviously, what is an irregular bleed, right? What is an abnormal bleed? So often when we say that, we just mean anything that is not normal for you. And this is why we always say, know you're normal, track your cycles. If you're having periods, track your periods and the regularity. Also, notice what it's like. Is it really heavy? Is it really painful? Has it changed suddenly? Are you now bleeding in between your periods? Are you bleeding during or after sex? Or you've gone through the menopause, which is Fiona's favorite topic, and then you've started bleeding. So all of these things is what we often describe as abnormal bleeding or unexpected bleeding. So if we do start from the outside of the anatomy, the vulva, when we think about causes of bleeding, they could include things as simple as infection. Okay, so if you have thrush, one of the most commonly occurring infections, a fungal infection that occurs. I think they say about 70 to 80% of us will have experienced it at some point in our life. Anyone with a vulva, women. And what happens is when you have that, the skin of the vulva can become really thin and irritated and inflamed. And also the scratching and the itching that can cause little breaks in the skin. So that can cause bleeding or any other vulval infection in that regard. Also, I wanted to take some time to talk about lichen sclerosus, which is more common than people realize. It is a chronic inflammatory condition. So it causes irritation, thickening, sores, and so on. And this is my cue to tell you to please, please, please check your vulva. You don't always get the bleeding, but if you're constantly checking your vulva at least once a month, then you will notice if there are any sores, if there are any breakages, or anything like that that could be causing the bleeding. So,
But
lichen
also don't
sclerosus.
heal up as well. Things like that don't heal. Keep an eye on
Exactly.
those things.
Absolutely, yes. If you're getting a persisting sore, it's not going away again, you can pick that up. But that can cause bleeding, that open sore, open wound. And then there are conditions like lichen planus or another condition called lichen simplex chronicus, which is essentially where the vulva gets really inflamed and irritated, and there's not much understanding as to why it happens. So you're constantly scratching it. Because you're scratching it, it then makes you itch even more. And because you feel itchy, you scratch it. And then that can lead to bleeding and excoriation marks and so on. And then, of course, rarely vulval cancer. That can cause bleeding in the area because, again, if you have an open sore or a wound because of the cancer or the cancerous lesion, that can lead to bleeding.
You mentioned the last one that you mentioned before you got to vulval cancer, which has just now gone into my ear and out of the other one, but a chronic lichen sclerosus type of situation.
Mm.
What's the difference between, because people often say they get told because they've got that chronic itching, they get told that they've got dermatitis. How do
Right.
you differentiate between the two? And is the treatment different?
Yeah, so that's a really, really good question. It's quite specialist. To be honest, it this is where there's a interlinking between the dermatologist and the gynecologist, okay? Because often they would take a biopsy. So biopsy really is how we find out what exactly is going on. You will get a definitive diagnosis of either lichen sclerosus or cancer, or if they couldn't find anything underlying, then perhaps it is that lichen simplex chronicus that I was telling you about. So really, the true answer of how they find out is with biopsy, and then treatment does vary, but often steroids are the course of treatment for lichen sclerosus, steroid for a longer period of time. And I didn't mention, obviously, after menopause, you go through, you have what's called atrophy of the skin. So the skin of the vulva around the vulva becomes quite thin, it becomes friable. And it's because, unfortunately, we've stopped producing the estrogen, which helps to plump up that area, just provide that moisture and makes it nice and, you know, soft and plump, as I say. So when we go through the menopause and then we have the atrophy happening, so the vulval atrophy, they now call that whole thing, the whole condition, the genitourinary syndrome of menopause. That can cause the skin to, again, be really thin and friable and can increase the chances of little tears and then bleeding occurring. So essentially, if you notice any abnormal bleeding in the area, even if it's just the tiniest bit of blood in your underwear, just get that checked out. If you want, examine it in the mirror. If you're not sure what you're looking for, just have your doctor have a look.
Easier said than done. It is extremely hard to get somebody to actually take a look, but yes, in theory, if you can pin somebody down and say, please take a look, you can, yes, it's not easy to get somebody to do that.
Well, if you go and see your doctor and you're concerned about something and you haven't been examined, you can ask them why they're not examining you and how they know for sure. That's advocating for yourself. If you feel as though you think there's something wrong and they've not looked at the area, really, we should examine the area, then you can ask them to.
Yes.
Or if they don't want to, and they shouldn't, but if they don't want to, then you can get a second opinion, see another doctor. I'm sorry if anyone has experienced that. It shouldn't be the case.
Yeah, it's very, very difficult, especially if say if you have, like, you know, 3 cases of thrush in a year or things like that. Are there actually guidelines or cutoff points where somebody should actually be having a look?
Yeah, no, absolutely. I mean, you can have thrush once or twice, but I believe it's 4. I think if you have it 4 times in a year, that's when it's called recurrent thrush, and really you should have long-term treatment for it. You should definitely have had a swab by then, because the thing with thrush is that it can present in a very, very similar manner to a lot of different conditions. So we've already mentioned a few of them, lichen sclerosus, vulval cancer, which is really rare, but it can happen, lichen planus, lichen simplex chronicus, you know, all these, I think vulvodynia also, some people experience an itch rather than pain, or the itch is so sore that it's causing pain, you know. So I would definitely push to encourage you to advocate for yourself and say, please, can you examine me? Or can I have a swab done? And sometimes they don't necessarily need to, in that moment, if say it's your second episode of thrush, they don't need to necessarily examine it. They can give you a swab for you to do the swab yourself, to confirm what the diagnosis is, and then have the appropriate treatment. But yes, get examined, especially if you see something, ask the doctor to have a look.
People tend to go on for a very, very long period of time as, you know, self-treating, thinking that it is thrush, like I did for years.
Yeah.
I didn't find out that it was vaginal atrophy, and that
Yeah.
I would have been a hell of a lot more comfortable if I'd actually had estrogen rather than Canesten for 3 years. So, yes, important to get looked at. Yeah.
Yes, absolutely. So then if we work our way up, right? So the vulva, it leads into this structure, the vagina, which is on the inside. Now, if you have conditions like, so vaginal atrophy, as we mentioned, because of menopause, the skin becomes really dry. That can cause bleeding. Sometimes if you have a really rough, rough session of sex, sometimes that can cause little tiny tears.
It doesn't even have to be rough, just sex.
That can cause a bit of bleeding and lacerations. And then, of course, very, very rarely, it can be vaginal cancer that can cause abnormal vaginal bleeding. Again, it's a source, the wound is the opening that can cause bleeding, the changes to the skin. And then if we move up to the cervix.
Before we get to the cervix, you can get polyps in your vagina as well, can't you? That could be a cause.
Yes.
Yeah.
Yes. So you can get polyps anywhere. Polyps basically is just an overgrowth of tissue, essentially. And you can have it in your bowel. You can have it in your, anywhere in your gynecological tract. You can have it in your cervix and your vagina. So it usually is benign, but there is a very, very, very small percentage of it then developing into something cancerous. Very small percentage. Often if there is a polyp, they will decide whether or not it's something that they will monitor over time, or they may take it out and then they send it off to the lab so they can confirm what exactly it is. But majority of the times it is completely benign. And because of that overgrowth, often they have a lot of blood vessels in them in the way that they grow, and that makes them really prone to bleeding. And again, if the area is rubbed through any sort of contact in that area, that can cause vaginal bleeding as well.
Fun stuff. Ways of avoiding that. I mean, I guess obviously if you've got vaginal atrophy, then estrogen is a really good thing.
Lubrication,
Moisturization, all of
yeah.
those. Any other brilliant tricks up your sleeve for that one?
Yeah, so estrogen is the biggest thing when it comes to vaginal atrophy, often the genital urinary symptoms of menopause, because like I say, estrogen is what makes the skin sort of thick and plump and just, more hard wearing, I would say. So if you have vaginal atrophy, vulval atrophy, your doctor would prescribe you estrogen. And as far as I'm aware, when it's topical estrogen in the area, so directly either onto the vulva or the vagina, even if you have estrogen dependent or sensitive breast cancer, they're saying that the amount that goes into your bloodstream is so small that it's very, very unlikely for it to cause a cancer to recur. So yeah, the thing is, like you say, having vulvar vaginal atrophy, for a lot of people, it can be so debilitating, irritating. You don't want to be scratching yourself in public, but that's the thing. It's so severe and painful, and then it can cause urinary tract symptoms. It can cause urinary tract infections as well, because again of the irritation and the thinning of the skin. So estrogen, and then moisturizers, as we mentioned. Be very, very careful to check the ingredients of the moisturizer, because some people are very, very sensitive to certain ingredients, so certain components. So yes is usually a really good lubricant that quite a few people have positive things to say. And subtle also, I believe, is quite good for some. But again, just check what works for you. Ones that have glycerol in, be careful, because that can increase your chances of getting thrush. So always look at the ingredients in the moisturizer. And if you've started using a moisturizer and you feel like your symptoms are getting worse, then it might be that you're sensitive to something within it.
Yeah, exactly. Other important things about that are the pH, making sure it's as close to somewhere between 3.8 and 4.5-ish, around that sort of close to what your vagina would be. And osmolality. And this is the thing that everybody, very, very few products have the right osmolality. It needs to be something that close to 380. And the vast, who says, as long as, because none of them are there pretty much, who is saying that, okay, as in the World Health Organization, as in, not as in who as an owl speaking, but the World Health Organization says under 1200 is acceptable, but if you can get it down as close to 380, that will be great. But the difficulty is that very, very few products actually say what their osmolality is. And the reason,
how many people will be looking for that? This is
I know. It's sort of like, do I have to have a chemistry degree to walk into the counter of my supermarket to get something? But basically, but at least if it doesn't say what the pH is, put it back on the shelf. If it's got a fragrance in it, forget it. If it's got glitter in it, forget it. Those sorts of things, they're not going to do.
If it's there to make your vagina or vulva smell of flowers or berries or anything of that sort, just no. Just forget about. And then there are certain terms like pH balancing. Look, your vagina does that by itself. And like Fiona said, obviously what you want is a product that the pH is a bit less, so more acidic, because that is the environment in which the good bacteria and the commensal organism inside the vagina, that's the pH that they survive. That's the pH in which they work. So yeah, be careful with those sort of things. And don't put soaps inside the vagina. Do not douche. Don't put any cleaning products inside the vagina. The vagina is self-cleaning.
Yes, the self-cleaning unit, absolutely, and even outside as well. Water is fine. Really, water.
But some people do prefer to use a little bit of soap, so they do say that you can use mild, unfragrant soap if you absolutely feel the need to use soap. And remember, only on the outside, and it has to be really mild and unfragranced, as I say.
A soap-free soap, or an emollient or something like that would be more soothing. A couple of questions here. Is it right, though, not to take estrogen without progesterone? I'm thinking it's the other way around. You must have progesterone if you have estrogen.
Yeah, so we're moving towards that. So, okay, let me just go to the cervix and then we'll go to the uterus and I'll answer that question right away. So, the cervix is this bit here, this donut shape right here. It's basically the neck of the womb, connects the vagina to the uterus or the womb. And what can happen is if you have there's something called cervical erosions, which happens on the outside of the cervix, or sometimes what can happen is you can have what's called an ectropion. So the skin of the inside of the cervix is different to the skin on the outside of the cervix. And what can happen over time as you get older, if you've had children, is that skin on the inside sort of comes out a little bit. And that skin is very friable and it can bleed quite easily. So that can cause unusual bleeding. And we can usually see that outside when we use a speculum. Also, you can get polyps. We mentioned polyps in the vagina. You can get polyps forming either on the outside of the cervix or on the inside, pushing outwards onto the cervix. And again, as I say, that can cause bleeding. And then if you have cervical infections, so any infections that have passed on through sex, gone in that way, that can cause irritation to the outside of the cervix. And also cervical cancer. It's cervical screening awareness week, so I have to talk about cervical screening. Please, 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 if you're due, please book an appointment, get it done. Cervical screening saves thousands of lives a year. It prevents cervical cancer from occurring. So please, 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 I know that it's not the most pleasant, most comfortable examination, and it's not easy for everyone, but it is just a quick 5-minute procedure. The procedure itself is even less. They put the speculum in. Sorry, got it. They put the speculum into your vagina, then they open it up in order to visualize the cervix, and they use this brush and they pop it here and gather the cells, send it off to the lab, and then you get results within a few weeks. Please, 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 please. Cervical cancer is preventable. If you're due, go and attend your screening. And if you are someone who struggles, say for instance, if you suffer with a condition called vaginismus, which is where you get the involuntary spasming of the pelvic floor muscles around the vagina or the vaginal muscles, speak to your doctor about it. There are different relaxation techniques that you can adopt. And I also have some posts on my grid about breathing strategies and also psychological tools that you can use to help with that. And if you've gone past menopause, we often say use your estrogen for a few weeks prior to having the examination done, just to help with the pain and the discomfort that you may feel. And also you can use lubrication beforehand, again, to moisturize it. Try not to do it on the day because that can affect the results. But on the day, they can and they should use lube. Okay, you can bring your own lube if you're sensitive to the one in the clinic. And the reason being, again, just to help to make the process smoother and more comfortable for you. Okay.
Water-based? Does it have to be a water-based lube if you're bringing your own?
Yeah, preferably water-based. Yeah. The reason sometimes that they say, oh, we can't use lube is because they say that it may affect the results. And that's true if it's on the tip of the cervix, of the speculum. You don't want the lube to mix with the cervical cells because yes, it can. So often they can put it sort of on the sides here to allow that smooth entry. Particularly if you're someone who's gone through menopause, but even beforehand, it just makes it just nice, a smooth entry, essentially. All right, so that's cervical screening, and that's the cervix. Now,
cervical screening, just one thing, because people get very confused about what it is they're actually testing for, and they think that they're testing for cancer cells, but they're no longer testing for cancer cells, are they? They're looking for the HPV virus. Yes. So why is that, and what does it mean?
Okay, great. This is my favorite topic. Let's talk about this for the rest of the life. All right. So yes. So the new way of testing is called HPV primary screening test. So essentially what they do is they test for the virus, human papillomavirus, or HPV. And the reason being is it's very, very closely linked with cervical cancer. In fact, the Cancer Research UK says that 99.8% of cervical cancer patients have the high-risk HPV. So high risk, meaning that they are the HPV that cause cancer. Now, there are hundreds of different strains of HPV, and there are 13 that they have found that's associated with cancer, not just cervical cancer. You can also get vulval, vaginal, anal, penile, and head and neck, so the throat and mouth cancer. with HPV. Now, that's the reason why they check for HPV first. So on the sample that they collect, they check whether or not you have the high risk HPV. Okay, if you have the high risk HPV, then they look for whether or not you have any cervical cell changes. So not cell changes that mean that you have cancer, but changes that is just not what is normal, essentially. And they could be precancerous. So that what that means is they could be ones that have changed and could develop into cancer. And it might be that actually that they will find cancer cells, but that is not the goal for screening. Screening is to try and catch the earlier ones so that we can prevent it from progressing into cancer. So if you have the high risk HPV and cervical cell changes, you get sent off for a procedure called colposcopy. Colposcopy is basically done it's usually done in hospital or a clinic with a specialist who looks at your cervix through a microscope, and they use it's a similar thing in that they use a speculum to open up the vaginal wall to visualize the cervix well. They look at the cervix. They use different dyes or liquid as well, just to see whether or not they can find abnormal cells. And either there and then, if they find something, they may treat it, as in remove some of the sample if you can tolerate it, or they may ask you to come in at a different time and then they'll remove it. And whatever they remove, they send off to the lab to get a confirmation as to whether or not it is cancer or if it is precancer cells. And hopefully they've gotten rid of it and treated you and prevented cancer from developing. So that's essentially cervical screening in a nutshell. What we're doing is we are testing people who are apparently healthy. So people who don't have any symptoms at all, who may potentially have precancerous cells, and we treat it before it turns into cancer. And that's how cervical cancer could one day be eradicated if we all attend our screening. I also want to mention that if you are having symptoms, then it's not screening that you need diagnostic tests. So if you do have symptoms and you think, oh, well, I'm having my screening in a couple of weeks' time or in 3 months' time, don't wait for the screening, please. See your doctor, tell them about your symptoms. Red flag symptoms that we talk about is the abnormal vaginal bleeding, as I mentioned. So bleeding during or after sex, in between your periods, or after menopause, those can be symptoms. And also if you're having like persisting pain in your hips, or your groin, or you're getting really severe pain during sex, you shouldn't feel pain during sex anyways, but just get these all checked out. It doesn't mean that it is cancer, but it's always better to rule it out.
Absolutely. There you go. A couple of questions here for you. Can exercise aggravate the area and cause bleeding? And I'm guessing this is coming back to more of the closer to the external areas than the internal ones. Can exercise make it worse?
I mean, it depends on the type of exercise that you're doing. I guess that if you are riding a bike and you're sitting on the bike constantly rubbing, so your skin is rubbing against the area, and if you do have thin, friable skin in the area for whatever reason, like we've mentioned quite a few, then yes, it may cause a bit of bleeding. And this is where it would be worth, again, you can do your self-check. You can have a look. Can you see anything there? Can you see any cuts or bruising or anything? And if you do, see your doctor. Even if you don't see it and that's happened, just get it checked out again, just so they can have a look, make absolutely sure that there's nothing going on. But I mean, if you've just done a long, I don't know, triathlon or something like that, and you cycle for a long period of time, watch out with the sort of fabric that you're wearing. And what some people do to prevent chafing is they put Vaseline on the area, sort of just to that friction. Yeah.
Menopause, Isle of Wight, I will come back to your question in a minute as we move to the uterus, which is where we are going next.
Yes.
Let's have a discussion about the uterus.
Let us talk about the magical place that the babies sit in for ages, for 9 months. Right. So if we talk about the womb or the uterus, which is this area, we have the inner lining, which is the endometrium, and then you have the muscular layer. And why I'm talking about the inner lining is the question that was asked. So the inner lining is called endometrium, and when you are going through your reproductive years, that's where you get the thickening of the lining of the womb every single month, and then it sheds. If pregnancy doesn't happen, that thickening sort of sheds. It comes out as a period. Okay. Now, if you have gone through the menopause, before that, the thickening is encouraged by sex hormones, particularly estrogen. Okay, estrogen is what causes the endometrium to thicken. Now, when you go through menopause, as we mentioned, you were no longer really producing as much estrogen. So the ovaries are definitely not producing estrogen anymore after you've gone through the menopause. I know everyone knows this, but just in case, menopause is basically when you have stopped having periods for 12 consecutive months. If you haven't had any bleeding at all for 12 consecutive months, then you have gone through menopause. And technically, it is just one day. The period after that day is called postmenopause, right? So if you've gone through menopause, but they have put you on HRT, hormone replacement therapy, to try and help with your menopausal symptoms. Now, that if you have a womb and we are constantly giving estrogen without any progesterone at all, so progesterone usually helps to keep the layer thin. It's what we call, it's a protector of your womb. Okay, so imagine if you're having HRT, you have a womb, and you're just giving what we call unopposed estrogen. You're just getting the estrogen constantly. That will continue to thicken, and if that goes unchecked, there is an increased risk of that eventually turning into cancer. So you need to be very, very careful. If you have gone through menopause, you are an HRT, you have a womb, and they've only given you HRT that just has estrogen, please speak to your doctor about it, because you need that progesterone. You need to be taking progesterone along with it. And that just helps to keep the lining thin, to prevent cancer from developing. So that is protective. Really important that everyone's aware of that.
It is, and as you, I mean, I know HRT isn't your specific area of speciality, but as you would be aware, we are going through a significant area of HRT shortages, and that has significantly affected utrogestin and making it extremely difficult for people to get that. If people, I guess that, at the moment we have stories of people who are rationing their utrogestin, and I've got to say I've done this myself when it comes to the last couple of weeks before I put the script in. Instead of using 2 a day, I'll drop it down to 1, because I think, oh my God, what happens if I don't get any for another 4 weeks or something? So at least I'll have 2 weeks to cover me over to find some sort of other alternative. So we've got people doing some quite desperate things out there, but there's also this in the back of people's mind that, oh, it's going to take ages for the endometrium to thicken up. It doesn't really matter. Is that a myth?
I will honestly say I'm not entirely sure. I think that obviously, if with regard to the progesterone dose that you are prescribed, often you are sometimes prescribed at even higher dose, isn't it? Because if you are someone who is still bleeding on the HRT that you're prescribed, they will sometimes give you some more progesterone to try and to cut back on the bleeding. So I don't want to answer that with confidence, like I know for sure. I mean, obviously what we prescribe is individually based. So it does depend on the individual, and we would encourage you to take what is prescribed, how it's prescribed. I don't know what would happen to each individual if they are rationing. I understand why it's happening, and it's such a massive shame that that's the case, but I definitely wouldn't encourage it, because we don't know. Every individual is different. I don't know if rationing it and missing, I don't know, a few tablets, whether or not that's enough to increase your risk of cancer. But logically, you shouldn't be doing it, because yes, you could be increasing your risk of cancer, because this over thickening of the endometrium, it can sometimes it just takes one thing to trigger it to eventually become cancerous. Do you understand? So I'm not sure is the honest answer.
But from what I gather is it can thicken up really quite quickly. And it's not sort of like, oh, it's going to take years to do that.
No. And that's why we tell you to take the progesterone every single day. There's a reason you're taking it every single day and at that dose. Or if you have the patch, that's why you will have it in your patch constantly being released to you. So that needs.
It does need to be done. The other thing that's ridiculous about this is the Mirena coil you can only get in certain sexual health clinics if you are premenopausal. it's on the prepayment certificate for HRT,
Yeah.
but yet I can't get it in a sexual health clinic, and very few GPs can put it in. So you're stuck
Yeah.
in a rock and a hard place, because you kind of think, oh well, logically I'd go back and have that put in and have 5 years worth of not
Yeah.
thinking about it again.
Yeah.
Now you think, well, I'm stuck, and there are a lot of people going through that, as
I
many
know.
writers saying over here. It's
I think it's difficult because the sexual health clinic have their capacity, right? It's not fair on the patient. There definitely needs to be more. I mean, I know that the women's health strategy, the plan is for there to be the women's health hubs, and hopefully these are the places. But it's just, do they have enough staff to be able to man this? And I don't know. We're hopeful.
is there
We're
place to
hopeful.
back that up? There's not much point in having a women's health hub if the policy doesn't say, yes, we're going to fund you to do that.
Yeah.
It's, they need, it's not all meshing together there politically in a way, is it? It's a bit fractious.
Yeah. I mean, there's hope.
There is.
I'm just trying to be positive and optimistic. There's hope. At least it's something that is being organized. I think that as long as, I guess, clinicians are involved in the process, it will make a difference. Yeah, it's a
Um,
shame. Women's health, the gender health gap is just, it's such a shame. But I think having people like you, Diane, Claire, everyone who is pushing for this change, having these conversations, being bold about these conversations, that's what's going to make a difference. So let's keep pushing, right?
yes, absolutely. Okie dokie. So we're inside there, and there are other reasons, of course, rather than the lack of progesterone. Well, actually, just one more thing that I might say on that is that if you're not bleeding, that doesn't necessarily mean that your uterus lining isn't thickening, is it? So don't
Yeah.
take bleeding as being the only sign of a thickened endometrium, because it can be happily thickening away, and you won't have a clue.
Absolutely. And sometimes that could be a later sign. So, yeah, if you are on HRT and you have a womb and it's only estrogen, please speak to your doctor about having progesterone. You should have it. I think sometimes what happens is there's just a miscommunication with regards to, have you had a hysterectomy, have you not had a hysterectomy, and why they're not on the progesterone. And I also think that there are not many patients who are aware of that link. So hopefully anyone who watches this will now know. All right, so moving forward, other causes of like maybe really heavy or painful periods. We always talk about cancer. Cancer is a rarer cause, but it can happen. So womb cancer is actually the most common gynecological cancer. I believe it's about 10,000 new cases every single year of people being diagnosed with womb cancer. So it's something that needs to be talked about, and that can happen anywhere in the womb. Also, if you have a condition called fibroids, which is basically, fibroids are benign growths that can happen in and around the womb, usually within the muscular layer of the womb. You can have, there's so many different types. There's intramural, which is inside, like deep inside the muscle layer of the womb. You could have submucosal, which is one that's pushing against the endometrial, subserosal, which is pushing along the outside, and you can have a pedunculated one, which is one that's sort of hanging with a stalk on the inside. Yeah. So fibroids can also cause like sort of heavy, very heavy bleeding, and for some people, even irregular periods. Also, if you suffer with endometriosis, you can have really severe painful periods. Very, 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 very painful periods. That's often the symptoms. And again, some people may have abnormal vaginal bleeding as well, or they can have bleeding during after sex. If so endometriosis essentially is where you have endometrial-like tissue. So the tissue that's similar to the lining of the womb in different areas, different parts, so outside of the womb. So it can happen on the ovaries, the fallopian tube, just anywhere. And if it's in certain areas, it can, again, if you're rubbing against it, it can cause abnormal bleeding.
There was a question here that came in a minute ago about endometriosis, and asking about HRT and the role of endometriosis. Can it make it better, worse? In what role does it play?
Okay, so very, very good question. Endometriosis is very estrogen dependent. Okay, so often, but not always, people who suffer with endometriosis, once they go through menopause, the symptoms cease usually, because, as I say, estrogen dependent. Now, this is where it becomes a catch-22. So some obviously not everyone will go through the menopausal symptoms and not everyone will have it bad, but if you are, and if you do have really severe menopausal symptoms or perimenopausal symptoms, the treatment for it really is estrogen, obviously HRT. Now if you are taking HRT, there's an increased risk that yes, it can aggravate your endometriosis and cause even worsening symptoms. So yeah, the jury's out. Depends on the individual, to be honest, and how they respond to it. But logically, if you are taking HRT and it has estrogen in it, then it can aggravate the endometriosis.
Yeah, then you've got that balancing act of getting the progesterone and the estrogen right. And even if you've had the endometriosis removed, they'll often say take a little bit of progesterone afterwards as well, won't they? Just in case there are other bits somewhere that they haven't got, just to sort of keep it under. Yeah. Very, very tricky one, endometriosis. So we've got fibroids, we've got endometriosis. What other things inside there can be causes of bleeding?
So we were talking about, essentially, when we talk about the thickening of the womb, there's a condition called hyperplasia, endometrial hyperplasia. So all that means is hyper meaning a lot or excessive, and plasia is growth of tissue. So if you're having overgrowth of tissue, hyperplasia in the endometrial area, that's called endometrial hyperplasia. You can have either typical, which doesn't usually progress to cancer. It's just that the lining is thickened. Or you can have atypical, which can have precancerous cells in it. So it can develop into cancer in some cases, and that's something they need to pay attention to. These are really estrogen dependent. So things like having PCOS, so polycystic ovarian syndrome, having diabetes, or even again taking HRT, those sort of things can, or hormone-based medication with estrogen, those can aggravate it to occur. And also if you are obese or overweight, because we know that fat cells release estrogen, so you need to be careful with that. So yeah, endometrial hyperplasia is another cause. And again, it depends on whether it's typical or atypical. Atypical, you need to be monitored as frequently as possible. Sometimes what happens is to investigate it, they do what's called a hysteroscopy. So that's where they use a telescope that has a light and a camera at the end, pop it through the vagina, in through the cervix to have a good look inside, and they may take some biopsies just to confirm that it's not cancer.
Yeah, that's it's an amazing thing to watch that, actually. I've had one and I was just fascinated. It's like, wow, that's what the inside of my uterus is. And actually it's a very good way of distracting yourself in a way, because it's not the most uncomfortable, but it's certainly not the most comfortable thing you could go through. But
No, of course.
Absolutely fascinating to watch if you're a nerdy type of person.
like Fiona. But I mean, those are the main ones that I wanted to sort of highlight. I guess the point of this whole discussion is to say that know what your normal is, understand your body, understand your cycles. And if you find anything that's not your normal, like I say, if your periods have become really, really heavy, or you're starting to bleed in between your periods, or you're bleeding during or after sex, or you are, just anything that's different for you.
Sorry, somebody just tried to call me. There was one, before we go, actually, there was one really good question here, and this is a really interesting one, because it's how much blood, at what point should you actually start worrying about? Because you could be having fresh blood, it could be a little bit of dried blood. What's the difference between the two, and how much is an amount that would make you be concerned?
Okay, so if you're talking about someone who's gone through the menopause, any amount, even if it's like pinkish discharge, get that checked out. So any type of bleeding, even if it's dried black, because that usually is indicative of old blood, get it checked out. You shouldn't have any of that colored discharge coming out of you, and you don't really get discharge, as much discharge, once you've gone through the menopause. But yeah, it could, like I say, it could, even if you're sort of premenopausal, so before the menopause, if you're having pinkish discharge coming out, or if your discharge has changed and it's become like brown or really foul smelling or black, those are all indicative of something going on potentially. And I mean, You shouldn't really be bleeding. Some people may have like a little, may have a little bleed, just what we call implantation bleed. They may have a little bleed in between their periods when implantation happens. So that essentially, if you have a bleed that's really faint and it happens over a short, like maybe a couple of hours or so, and then you don't get a period at all, do a pregnancy test because you could be pregnant. But I mean, it's a really good question. Honestly, like I say, it is what is normal for you. So yeah, even if it's pinkish or brown discharge or any black discharge coming out, it doesn't have to be fresh red blood to signify abnormal bleeding. I mean, obviously, if it's profuse, that's bleeding. But yeah, I would say any of the things that I've just mentioned. I'm not saying that it's anything sinister. It could be a simple infection. It could be like a little graze, after having intercourse or something along those lines. But always get it checked out, because it's always best to get it ruled out. As it's best to get anything more sinister ruled out.
Safe than sorry. There was a question here actually about the fat cells producing estrogen, and just to make sure that I've got this correct, it's normally estriol, not estradiol, isn't it? It's a different type. There are 3 different types of estrogen.
Oh yeah.
The estrogen shouldn't necessarily make any difference to the amount of HRT that you're having. And even if it did, I mean, you're still having your HRT and you're being prescribed it for the amount of your symptoms. So they're not giving you an overdose of estrogen.
Yeah.
Different from your estradiol. Does that make sense?
Yeah, I think the doctor will go by you as an individual, as a patient. They will assess your risks. So, a patient who is obese, smoking, and maybe family history of breast cancer, that we look at the whole picture before we give the prescription, and whether or not, it's not contraindicated. We can't just give HRT to everyone. We have to look at the individual and their individual risks.
Yeah, absolutely. Is there anything else? Are we done?
Yeah, pretty much. That's what I was going to talk about. If there's anything more that you can think of, I don't know.
didn't think so.
I've not been the best today. So if there's anything that I've forgotten, you guys can send me a DM, and then I could probably make a reel on it or something. But a lot of what we've talked about, I often post on my page, Dr. Sesay. So if you want to have a look, or you can check out the website. Newsletters will be coming out soon once I get the time.
Brilliant. Well, that's something to subscribe to. And so yes, so when people want to do, you've got your website now, which is Talks with Dr. Sesay. So it'll just pop. Google's that, won't they? And you're speaking at Cardiff this weekend, yes?
I am, yes.
Mm-hmm.
So the first of its kind Women's Health Festival. I'm so excited. There's just a wealth of information, a wealth of knowledge, so many people from different specialties as well. I mean, you have physios who will be there. I mean, you have campaigners like Love Your Periods, Molly. I think she's so cute. I really like her. She'll be there as well. I mean, Jo, who's written the book This Is a Vulva that I edited and reviewed, she's going to be there too. And Emma, who's a physio. There's just loads of different people. It has been founded by Julie Cornish, who is a colorectal surgeon. And it's just talks on things that is often considered taboo, and it's met with loads of stigma and embarrassment. And it's just to have this conversation to try and bridge that gender health gap and just encourage more of the conversations, because there are so many people suffering in silence, thinking that what they're going through is just one of those things that they need to get on with, which isn't the case. Just because I heard someone say this the other day and I really liked it, just because something is common doesn't mean it's normal. Okay, so prolapse is common, incontinence is common, but it doesn't mean that you need to continue to suffer with it. There are options and there are things that can be done to help to manage it. So if you're free and you're around and you want to join us, I'm one of the main stage speakers. I'll be speaking at 11 a.m. and then there's a meet the expert session, which I'll be leading afterwards. You can ask me more of these sort of questions if you want, or if you just want to meet me in person, I'll be there. And then, like I say, I think there's like yoga and Pilates and food, and it's just going to be a fun day for all. Join us.
Where is it on it in Cardiff?
Insole Court. So Insole Court apparently is this beautiful castle. So you get that. And it's in Cardiff, which is central. Yeah. I don't
Yay.
think there's parking on site, but there's parking sort of maybe 5-10 minutes around. Otherwise, catch a train, come and see us.
Yeah, brilliant. Absolutely. I might do that. I might jump in the car and whiz up.
Really? Yes, that would be nice. I haven't met you, Fiona, even though obviously we've known each other through here for like, I don't know, a year or two. I'd love
Yeah.
that. Come.
Can you buy tickets, or is it how do people get tickets if they're in Cardiff? Or if they
Of course. I'm not doing very well at selling.
just come.
Just come. You just need to show up. No. Sorry. You have to get tickets. So go on to the everywomanfest.com. I believe that's the website, everywomanfest.com. And you can get your tickets from there. Or if you go on to they're all over social media, actually. They're TikTok, Instagram, LinkedIn as well. I think Facebook. So if you want to go onto their pages and then you can click to buy the ticket. The tickets are £15, and you get access to one seminar and one workshop, plus everything else that's going on in the day that you can just drop into. And like I say, there's loads of food and just, yeah. I think what I love most about this is it's the first of its kind, and it's just there for us to have these conversations. It's not just for women, it's for all genders. Everybody come and learn, because everything that affects more than 50% of the population will indirectly affect everyone. So it's important that we're all aware of it. And you, even if you're not a woman, you will know someone who may go through what's being discussed. So yeah.
Absolutely. Brilliant. All right. Well, look, thank you so much for that. And enjoy the weekend. And hopefully I will see you again soon.
Yeah, no, thank you so much for having me. I hope this was useful. I'm in one of my moods today, honestly. So if I've said anything or I haven't correctly mentioned anything, let me know. Or not, if I haven't adequately informed, let me know, and I will go through with you another time.
I think it was lovely. Brilliant. I will let you go, and I'll talk to you soon. Take care.
All right, you too. Bye.
Bye.